What I am going to do for you today, I'm going to do half a cahoots. Okay, there's 90 questions. You guys are busy. You have things to do after this. So I'm going to do half a cahoots with you. I now teach after this another class tonight. I'm going to do the other half. So I'll send you 2 recordings. Okay, but it will be on the 90 question HESI review. Now I have put in your announcements a 90 question and a 100 question cahoots, okay? The 100 question cahoots is a little older, but it doesn't mean those concepts are not around. It's just I made, and some of them you'll see in the 90 question one too. But the 91 is one that I worked on this semester. It is up to date. It has all the concepts that you do need for the HESI. I do what we call a gap analysis. And all it does, it tells me the concepts of questions and those questions that students mostly missed. So if I see that, I'm going to put it in a cahoots to make sure that it's covered. I have done that in every week cahoots the entire semester. That's why I'm always renewing and reviewing. So you have the up-to-date information. You have cahoots weeks 1 to 9. You have the 2 HESI reviews, 90 and 100 question, and you have a really big PowerPoint. Now that PowerPoint is over 200 slides, but over 100 slides are questions, and it's a question then an answer. So each one is 2 slides. So it's actually 50 questions. So don't be overwhelmed by it. So go back and test yourself on those questions when you're done. They're excellent, excellent questions. So let's go ahead, share the screen, and let's see who wants to win a cahoots today. And it's only going to be the first 45 questions. Because I think after 45 questions, your minds are going to shut off. You just took an exam. You probably just had another exam or studying for another. Now, if we're going over these questions and you're not understanding something, please ask questions. Okay, if you don't understand it, stop me, ask me something. Let's just get going. Let's get her going. HESI review 2022, unbelievable. What is probably the single most important influence on growth at all stages of development? And you've heard me say this over and over and over again.
Nutrition. I'm sorry.
Nutrition, 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 nutrition. If a child's not getting the proper nutrition, can't grow. The muscles don't get anything, the nerves don't get anything. They're cognitively, they're going to be delayed. Plus, they're not going to grow as they should. Nutrition, so important. Frequent developmental assessments are important for which reason? Like, why do we look to see if they can roll over, lift their head, pincer grasp, crawl, walk, run? Why? It's because if they're not meeting milestones or moving forward, as I've always said, they can skip things like Yulima was saying. Your children never crawled. They got up and ran. And that's not abnormal. It can happen, but they're going forward, which means we know cognitively that they're aware and we don't have to do any sort of intervention. They don't need it. They're okay. The head to tail direction of growth is referred to as. So it's lifting the head to walking. It's basically what it says. So it's called cephalocaudal, okay? From the head, cephalic, right? Caudal, which means down to that walking, crawling sort of thing. So that's just the word to remember. What is the single most important factor to consider when communicating with children? You know, children are great and they'll do a lot of things for you, but you just can't walk in there and think they're going to cooperate. It's not going to happen. So what is their level? What do they understand? And then it's explaining to them what's going to happen on the child's developmental level, and then let them touch everything. Let them play with it. Bring a doll. Do whatever you need to do to show them what's going to happen to them. And the kids actually love it, and you're going to get a lot more done. Taking a little time does work. What 2-year-old pain assessment tool should the nurse use? So we know we have FLAC, we have FACES, we have numeric. Those are the big three that I see used. And you're going to see that we do document pain every single shift. So it's FLAC, which means that, yeah, maybe can they use a FACES? Well, maybe, but we know that an accurate assessment is done by looking at their face, the way their legs, their activity, their crying, their consolability. Those things really accurately will tell us, are they in pain? What's going on here? What is priority treatment for a child with dehydration due to profuse vomiting? So what are you going to do? What do you expect? What's the doctor going to order? I mean, we know dehydration in children is extremely serious, and we need to correct it as soon as we can. And if you're vomiting, do not give that child anything by mouth. Rest the stomach, give them an antiemetic like a Dovsteron, Zofran, and give some IV fluids. And that will help the child get the stomach settled and be able to drink slowly afterwards. The first expected fine motor developmental milestone for an infant begins with, remember, F, fine, fingers. Remember always to read the questions. You know, G, gross, get up and go is all motor. Fine is fingers. And it talks about the first is when you put your finger in an infant's hand and they grasp it. It's a reflex. And then it goes to voluntary. Then it goes to crude pincer, knee pincer. These are things that we evaluate developmentally. Is the infant doing what they're supposed to do? An 8-month-old infant should be expected to perform which fine motor skill? So we know we reflex, and then we voluntary. Then we're going to grasp a rattle, probably hand to hand, about 7 months. And then it starts with the crude pincer, which means sit at the high chair, put some Cheerios out. They sort of smush it in their mouth. It's not accurate, but it's crude. Might be a couple fingers, but they are using their fingers to get the food in their mouth. And that's crude. In general, an infant should triple their birth weight at what months of age? You know, and if we know what it should be, if it's too little, too much, then there's an intervention we need to take. It doubles at 6 months, triples at 1 year. Some important questions. You'll see that, I believe it was on the NCLEX, one of my students told me. An RN assessing a 2.5-year-old toddler should report which finding to the provider? Something's not right. What is it? So when a baby is born, they have huge heads. As they get bigger, the chest gets bigger than the head. And if we're seeing the head still too big, something's wrong. Is it hydrocephalus? Is it a tumor? Something's not right that needs investigation. So the head circumference should be less than chest by about 1.5 to 2 years old. A mother with a 3-month-old infant is concerned because the infant's head is flat in the back. What are you going to tell her? Well, we know everything's back to sleep, right? And a lot of times they're laying, and they sleep on their back, it gets flat, the hair wears off, and the parents don't like that. So remember, their heads are very soft, malleable. So put them on their tummy, do that tummy time and get them off their back of their head. And it does actually go back to being round because their heads are so soft. So that's the way we do it. We don't put them on their side, no, because they'll inhale their breath, which could be carbon dioxide. So we don't do that. And we don't put any pillows, no, because it has to do with airway and soft stuff, and they can smush their face and sense death. So we don't do that either. A 2-month-old infant has cradle cap. What should the nurse tell the parents to do to treat it? That's when they get that white, flaky, sort of dandruffy looking stuff. So you just wash it normally with soap. Then you take a little fine comb and just very gently you brush it. You're not getting it off in one sitting. It's going to be over time and it will go away. So, but it is washing it and very carefully, gently with a fine comb. That's the treatment. What information about introducing solid foods to their 6-month-old infant would you offer? For the first 6 months of life, they only get milk, whether mother's milk or iron fortified formula. Their bodies don't tolerate food. It just comes out in the stools. So when we start feeding them, it's one at a time, 4 to 7 days in between the offering of another type of food. Children do have allergies to food. And the only way to find out what food it is by one at a time, and then the span of 4 to 7 days in between each different food that you offer. According to Kohlberg, pre-conventional level of moral development, a preschooler who has moral reasoning, what does Kohlberg talk about? Remember, Erikson, Kohlberg, Piaget will be on your HESI. Make sure you do review those. Kohlberg's all about good and bad, and there's a consequence for each. Some children know what they know to be good because they want that praise. And other children know what is bad, but at this point, they're actually saying, well, I know it's bad, but I'd rather do it than not because I want to do that. So good and bad do have consequences. And then they start, as they get older, outweighing, do I need to be bad? Or should I not do that? Is the reward better than, the punishment actually? So what nursing action is appropriate to teach a preschool age child about a scheduled procedure? So preschooler, ages 3 to 5. Child's going to go have surgery, x-ray, whatever. This is the child that you are going to, number one, get on their developmental level. It's always one. But then we're going to get a doll. We're going to get the equipment, let them touch, feel, show them. And it actually, they know it's coming. So they're actually going to behave and cooperate during the procedure. Before performing a physical assessment on a toddler, the nurse should do what to encourage cooperation? So this is the time where, okay, with the answers that are here, absolutely let them touch it. Get on their developmental level, explain it, and let them touch it, feel it. You know, I can't tell you how many blood pressures I've taken that kids had to push the button. But you know something? In the end, the child was still, and I got an accurate blood pressure from them first try. So it is worth it, you know, to take that time. In terms of language and cognitive development, a 4-year-old child would be expected to do what? 4-year-old preschooler. And that's being able to follow simple commands. You know, even your older toddler, take your shoes, put them by the door. Take your dirty clothes, put them in the hamper. They should be able to do that. And Yuli, look at you way up top. Parents are concerned your 8-month-old child's not developing like their older child. What's normal for 8 months? So an 8-month-old child should be able to sit unsupported, not with pillows around. They should just be able to sit there. And as long as they're doing that or close to that, this child is normal. Remember, every kid is different. Not every child develops like their brother, their sister, their niece, their cousin. Every child's different. An infant presents with signs of dehydration, hunger, and an olive-sized mass in the right upper quadrant. What would you monitor for? What do you think this is all about? An infant, dehydrated, they're hungry, and they've got an olive-sized mass. Sometimes it's right upper or right mid or in the mid quadrant. This is pyloric stenosis. So what are we going to look for? Are they dribbling or are they across the room projectile vomiting? So what do you do for this child? Number 1, NPO. Start an IV because they need the fluids. They will go to surgery. After surgery, they'll start with clear liquids. These kids do not have a long-term problem with this. It's just that it's really tight sphincter, and they do a pylonotomy where they just open it up. So fluid can go down, and then they're not hungry anymore. A multi-select. What would alert the nurse to hold the digoxin on an infant she's caring for? So we know signs and symptoms of stuff, what to look for, but this is an infant. They can't tell you anything. You have to look at the kid and figure it out. So number 1, infants, digoxin, adults, you have to have a heart rate that you need to look for. That's number 1 because it can show digitoxicity. But vomiting, big thing is vomiting in children. They can't tell you about yellow spots and nausea and all of that stuff, but they will be vomiting. And of course, a dig level of 3.3 is way higher than it should be. It's 0.5 to 2. Higher than that, you're in trouble. So if a kid is just vomiting even with a borderline heart rate, I'm going to hold it, call the doctor. I'm going to do a level if I don't have one. When taking an adolescent's health history, which is important, you know, adolescents most of the time do not want to talk in front of their parents. So to get an accurate history, have them leave the room and they could, you know, talk to you a little bit better. Of course, open up conversations, talk about social things, you know, break that ice. But you don't have to tell the parents what they said unless it's something that could cause themselves or other harm. So that's one way that you can get, you know, an adolescent to talk to you. It's important to know why they're feeling or why things are happening to them or why they're ill. A multi-select. What assessment of an infant would indicate acute respiratory distress? So infants can't tell you they can't breathe, but the two things that you will see is nasal flaring. And then if you hear nasal flaring, and on the end of a breath, you hear, that's considered a grunt. This child is just about to crash and burn on you. This child is really severely in an acute distress. So nasal flaring, grunting. They always have abdominal breathing. Respiratory rate of 30 is actually low on an infant, but borderline low. And all infants have bronchial breath sounds. That's normal. But nasal flaring, grunting, you might see retracting, tachypnea, heart rate up to 200, respiratory rate of 80. Now that's distress, but these two assessments, most important thing to look at. A 4-year-old is reluctant to take medicine. What intervention should the nurse take? How are you going to get them to do it? Give me a second. With infants, you need to do that straightforward approach. Okay, do you want liquid? Do you want a pill? Do you want it in a cup? Do you want it in a spoon? And that's how you do it. That's a straightforward approach. Which concept reinforces the development of a sense of trust for infant? So this is Erikson. Excuse me. So Erikson says that infants that are being cared for, they know when they cry, somebody's coming. So they can predict that what they need, they're going to get it. And that's what Erikson's about. It's not about being accepted, anything else. It's predicting, I know I cry, mom's coming. I know if I'm wet, I'm going to be changed. And that is, they know that their needs are met. And that's a happy baby. An infant's NPO can't take a breast or a bottle. What do you need to remember to promote that growth and development for this child? Tracheoesophageal fistulas, or, something their NPO that can't eat. Give them that pacifier, that non-nutritive sucking, because this is where they relieve their stress, right? So they need that, and it also helps with the sucking, and it's comforting for them. When teaching sex education and contraceptive for adolescents, what should the nurse consider? So adolescents, you can teach and you can offer information, but only information, and you need to give it in written form, not your opinion. But if they're asking you for information, give it to them, talk to them about it, and give them a pamphlet or information or what to look, or a website, something where they can get proper information. The monthly immunization for RSV is what? We use these for those children who are immunocompromised, premature, cardiac children, because we don't want them to get, this cold. It's a virus with a lot of mucus. and it's called Synagis or palivizumab, and it's given through like fall into the spring, and it's every month. And this will help them from getting this because babies have a hard time. It's only the first year of life. Babies have a hard time sucking, swallowing, and breathing, put mucus, and they breathe out of their noses. They don't know they can go through their mouth. So you clog it up, they're not going to eat properly. And then again, you're going to have problems with nutrition and those problems to follow with cognitive development, et cetera, et cetera. An infant with hypoplastic left heart is becoming tachypnic, taking long to eat, requires rest. What assessment is priority? What are you going to look for? What do you think is happening to this child? So tachypnic, they're not breathing good. So if they're not breathing good, they're not getting oxygen. They're going to take a long time to eat. So they're really not getting nutrition and they need a lot of rest. It's probably their lungs are filling up with fluid. Cardiac, congenital heart defect, the heart's not beating right. So it's not going to pump the fluid around a lot. So many times they get into congestive failure. So auscultating the lungs, we can determine, okay, it's the lungs, do your x-ray, maybe diuretic. And then of course, daily weights, we'll be monitoring to see if it worked. When doing an admission on an infant with low-grade fever and a loose cough, what information is priority for you as a nurse? Where are you going to place this child? Kids being admitted to your floor. And we want to know about their immunizations because don't assume this is RSV or an upper respiratory infection. This could be something, could be pertussis, could be a lot of other things that it could be, which if they were placing this infant with another infant, could be dangerous. So immunizations are important to know if they have them, if they're up to date for placement of children. When administering antibiotics for a child with pharyngitis, what should you monitor? So you have a child placed on antibiotics. I don't care if they've been on them before or not on them before. In fact, many times it's on the 10th time they've been on an antibiotic, they could have an allergic reaction to them. So if you're giving antibiotics to a child, always, always, always monitor for any sort of allergic reaction. It could be as simple starting with a little cough, or it could be a rash, or it could be lips are getting big and blown up. I mean, to the extreme. So make sure that this is something we think about it when we're putting up antibiotics. Go back, make sure you check that child again after you give your dose to them. When teaching a parent of a child of a newly diagnosed acute lymphocytic leukemia, what are signs and symptoms of an infection? So ALL doesn't have white blood cells. They have no immune system. So they still get infections and it needs to be treated as quick as we can. So understanding early signs, we can get that child to the physician and placed on antibiotics quickly. So they're saying it's rectal temps that should be done. And if it's greater than 100.5, an axillary temp of 99.2, well, is it 100.2? Is it a degree higher or lower? It's always, we don't know. It's a subjective thing. But rectal temp of greater than or equal to 100.5, that's the beginning of we consider a temperature. So that child needs to get to the doctor, needs to go to the ER, wherever, and get IV antibiotics as quick as we possibly can because there's no immune system. A 3-year-old is brought to the ER with increased wheezing for the last 2 days. The child is using an MDI. What information is most important to ask about this? So they're using an MDI, that meter dose inhaler, but are they getting the medicine Can a 3-year-old push it and inhale at the same time? But using that spacer, we know they're getting it. I mean, somebody who's getting an MDI with a spacer, who is increasing wheezing, that is an emergency. But is it because they didn't have a spacer, they're not getting medicine? It's two different sort of children that you're working with. Put on the spacer, let them do it again, and you probably will see improvement if they didn't have a spacer. A multi-select. What is included in the plan of care for a child with cystic fibrosis? You know, cystic fibrosis is lungs and it's, nutrition, small intestines and, inability to absorb fats, right? So what do we do? How do we take care of this child? Well, we're going to take care of that lungs. Aggressive physical therapy. We're going to use those vibrating vests on these children. They're going to get a minimum of morning and night aerosols with a vigorous chest PT. They need high protein. They need that nutrition. And of course, pancreatic enzymes immediately before they eat. These children secrete salt. They need salt in their diet. They're losing it. So this is your child that needs salt in their diet. It's not going to be like a nephrotic syndrome or another one that is low salt. This one is normal salt. In fact, give them a salt shaker. Which information is most important when rheumatic fever is suspected? So there's two things that we worry about with rheumatic fever, with strep or pharyngitis. Rheumatic fever and acute glomerulonephritis. Both of those can be caused by a sore throat or an infection that wasn't treated or not treated correctly. So I'm going to ask, has your child been sick lately? And that will probably tell me the answer. Remember, rheumatic fever, everything can be turned around except for that heart valve damage. That can never be turned around. How do we treat it? Antibiotics. A multi-select. What are some assessments that an infant would have if they were in acute respiratory distress? And again, nasal flaring, grunting. Slow, deep respirations, that's not acute. It's going to be, very shallow and very fast. Respiratory rate, it's going to be way too high. If it was the end stage of acute respiratory distress, where it's at the worst part, you might see respiratory rate of 10, okay? It goes to the point where they stop breathing. What is the purpose of giving indomethacin to a neonate with a patent ductus arteriosus? So indomethacin stops the prostaglandins from being formed, and prostaglandins keeps that duct open. Now, talk about fetal circulation. We need to connect the lungs to the body. It is done by pulmonary artery to aorta, this little duct called a PDA. During pregnancy, mom secretes prostaglandins. Now, sometimes after birth, these prostaglandins continue and this duct keeps open. And when we don't need it, we have to close it. So we have to block those prostaglandins. And how do we do that? We give indomethacin, and then the duct closes. And then I say, how do you know the duct closed? Well, PDAs sound like a machine murmur. You hear almost like a washing machine murmur, they call it. If you start to hear that murmur starting to get less and disappear, we know the duct is closed. What is the greatest risk factor for a newborn getting a cardiac catheterization? So cardiac catheterization is a big catheter inserted to the femoral artery and the femoral vein. And once it's done, they take the catheters out, apply pressure. We do pressure dressing. Sometimes we put a sandbag, depending on, how big the child is, if they can tolerate it, if we have a small enough one. But if it opens and starts to bleed, it is like a big hose. And children, especially newborns, can lose blood quickly. So the biggest risk factor is nothing else but the hemorrhage. That's why we look at that first. Child comes back, I'm going to look at that first. Which symptoms exhibited by a 3-year-old child with croup is priority concern? So croup is, the oral pharynx. It's just not, you can't breathe. It's swollen in there. And you're constantly barking, coughing, which swelling gets worse. If you stop being able to swallow, which means you probably go into epiglottitis. So not swallowing those secretions is priority working. So they're going to be barking. They're going to be barking all the time. It usually is at worst, and that's when at night, and that's parents will bring their kids in at night. But it's that swallowing. Now you're going to epiglottitis. Probably start drooling too. A 10-month-old status post VSD repair is getting the morning meds. What med should the nurse question? Blood pressure is 118/70. Temp is 99. Pulse is 88. Respiratory rate 22. We know that heart rate of 88 is too low, so that's digoxin. Vasotec and allopril have to do with blood pressure. Blood pressure is fine. Furosemide is diuretic. Nothing there shows me that there's a problem, with fluid. Digoxin, it could be as simple as a heart rate. What do you check with adults before you give digoxin? Heart rate, right? Apical pulse for 1 minute. Well, assessing a newborn, you notice there's decreased femoral pulses bilaterally. What nursing action should be next? Number one, why would a newborn have decreased or absent femoral pulses? How would you say you would even diagnose what's going on? Well, when you're not, it's a newborn, brand new baby. There's no blood going down to the feet or minimal, probably coarctation of the aorta. How do you determine that? Do a 4-extremity blood pressure. The blood's not going down to the extremities, the low extremities. You have low blood pressures in the low extremities, and your upper extremities, there's going to be a higher blood pressure. That's the way you actually can diagnose before even going in and doing an echocardiogram. Okay, so coarctation, decreased or absent pulses in the lower extremities, higher blood pressures up top, lower on the bottom. How do you get an adolescent to open up about their sexual history? we've already talked about having the parents leave the room. We've already talked about giving them information about contraceptive in the written oral form. And how do you get them to get there to talk to you about it? Well, hey, I noticed that you're listening to music. What music do you like? Oh, those are cool sneakers. Hey, you got a purse. What brand is that? Or, oh, that shirt's cute, or whatever. You start that and they'll start talking with you. And it really does work. They like it that you pay attention to them. A multi-select. When educating adolescents about the risk for HIV hepatitis, what would you include? I mean, we can't assume that adolescents understand some of the risks they take, with HIV and hepatitis. So we know abstinence is what we should always promote. That's not means they're going to do that. Condoms, if they're going to be with sexual intercourse, and always hand washings. I mean, I hope they take a shower more than once a week. I would hope that. What stage of Erikson would you use for a school-age child? And then I'll ask you, what does it mean? This is probably the most common of Erikson questions. Infant and school age, they love these questions, especially on your NCLEX. So school age children like to do things and do it well. That's their industry. They're good at math. They're good at playing a piano. They're good at soccer. And inferiority is what they are not good at. And they wish they could. And because they can't do it well, they feel inferior. So industry versus inferiority. Remember that. Also remember your trust versus mistrust. That's infants. These are the two that are loved to be over and over and over again and asked in many different ways. A multi-select. A child with hemophilia has fallen, the knees swollen, painful. What would you do? How does this child treat? What would you teach them? Because they're probably at home. So we're going to elevate. We're going to do a rice, right? Rest, ice, wrap it up, and elevate. We're not going to exercise, and hot packs will increase the swelling on this child. And if this child has home hemophilia treatment, we're going to give home therapy, whether it is the vasopressin or a factor, whatever it is, we will, because we want to protect that knee joint sac, because we don't want it damaged. We don't want this child end up in a wheelchair because the joints are damaged. And last question for now, discharge teaching for a child with cystic fibrosis about respiratory secretions should include. So the most important thing is chest CPT. It is postural drainage. It's the aerosols. We want to keep those lungs moving. So very good. Let's see who's what where. Look at that. Z's up there. Marjorie, Suzette, Julie, and LaChanette. So please sign your attendance attestations. Okay. I will be sending out this recording, and tonight when I finish up, I'll be sending the other 45. And I got you right to 5 o'clock because I know how important